Right, so I'm just let you know we're just recording, and I'm very pleased to introduce you to Sarah, who's going to give us a rundown on osteoporosis and the types of medication and minerals and supplements that one can take for medication. Sarah, welcome, and thanks for joining us because your placement's now ended, so it's great to have you back. And please feel free to start, and I'll jump in and support if needs be.
Great, thank you. Can you hear me? Yeah, good. And can you see the screen? Is the PowerPoint on the screen now?
Yeah, we can see it.
Perfect. Oh, so it's going to scroll down, it seems, but that's fine. So this is the presentation on osteoporosis and the medication. So this first slide is just a little recap of osteoporosis. And so, as you all know, osteoporosis is a reduction of bone density. This is usually caused when osteoclasts work faster than osteoblasts. And this happens usually with age. So they say that once you get to 40, your osteoblasts start working slower than your osteoclasts. But when you're younger, your osteoblasts work a lot faster. And then it's more common in women than it is in men. This is for two reasons. So first reason is that men have a higher bone density to start with. So with age, it takes more time to reduce. So they've got lower chance of getting osteoporosis. And also with the menopause, so estrogen has a big impact on bone density as well. So that estrogen causes the osteoblast to be activated. So that's a benefit. So once you get into menopause, then bone density reduces. Risk factors, steroid use, medications for breast cancer, low BMI can be an impact as well. And the most common injuries because of osteoporosis are wrist fractures, spinal fractures, and femur fractures, I think, but that's gone from my slide. Yeah, vertebrae, hip fractures and wrist fractures. And then ways to diagnose this is a DEXA scan. On a DEXA scan, a normal good reading is 0 to -1. Low density is -1 to -2.5. And then anything lower than -2.5 is osteoporosis. And there's also a scale called FRAX, and that's a form that can see your risk of fractures. And it can be a useful tool. So as Tim was saying before, bisphosphonates are probably the most common use from a GP for managing osteoporosis. And so we'll go into that in a little bit more detail in a minute. But these first three medications are used as well. So we'll quickly touch upon those. So there's a selective estrogen receptor module. So it acts a bit like estrogen, so it increases the osteoblast function. So it's just replacing, so it's used in women, it's just replacing the act like estrogen to replace what you've lost. And then you've got your parathyroid hormone, which helps to increase calcium into the bone. So it's there to try and increase the strength in the bone. And then you've also got your HRT, which isn't as commonly used specifically for osteoporosis, but it does help with osteoporosis. So if you're going to the GP, they probably wouldn't give you HRT purely for osteoporosis, but it can be beneficial. And then the bisphosphonates, which are the most common. There's 4 main types of bisphosphonates that are used generally. You've got your anhydronic acid, which is taken in tablet form, and that's probably the most common. And then you've got your ibonic acid, risbonic acid, and zolonic acid. The zolonic acid has is probably the strongest one, and it's probably the most expensive as well, and it's done by injection. So the bisphosphonates work by attaching to a receptor on the bone surfaces, and it stops the osteoclast like reacting as much with the bone to break down the bone. 1 second. Put some notes on this one. Yeah, so there's a binding site on the bone called Bisphosphonates, which is a receptor that which normally the osteoclasts attach to. So what it does, it attaches to the osteoclast. So as the osteoclast goes to break down the bone, it reacts with the bisphosphonates, and the bisphosphonates releases a chemical which prevents the osteoclasts developing and stops them reabsorbing the bone. So that works to stop the reabsorption of the bone. So then you've got less breakdown. And also it does help a little bit with promoting the osteoblast, but it's thought that the benefit it has to the osteoblast isn't as great as the benefit of stopping the osteoclast breaking down the bone. Yeah, and it increases the bone density by 50%, and it can help to increase the calcium levels into the bone as well, and reduces the calcium in the blood as well, which can be something to be aware of. There are some side effects to bisphosphonates. So bisphosphonates can increase risk of femur fractures, can reduce healing after trauma, can lead to memory loss and cataracts, and as many drugs can be irritating to the stomach lining.
Hey Sarah, can I jump in?
Yeah, jump in.
You think, so we had a lot of chats, and I think it's remarkable that a medication such as bisphosphonates, which is used for low bone density, actually seems to have a increased risk of femur fracture, which is one thing that's actually designed to prevent, can cause reduced bone healing and hypocalcemia, so it can draw calcium out of the bones. And it's amazing that actually don't want that calcium in the bones to maintain the bone strength. It's always, well, it seems to me to be quite a interesting tug of war between benefits versus the side effects of alendronic acid and other bisphosphonates.
Yeah, so as Tim was saying, so the bisphosphonates increases the bone density, but it also inhibits the osteoclast, which is its job. But in some cases, that can be a negative point, because the point of the osteoclast is to help remodel the bone. So in a healthy bone, you'd have the osteoclast would break down any damage, and then send osteoblasts to remodel it and make it. But if you've got no osteoclasts to break down the damaged bone, you've just got damaged bone sitting there, and that can cause to weaker areas. So that's why quite more common of this fractures is in the femur, because you've got a lot of high pressure force going through it the whole time. So a lot of trauma to the same point loads of times, and then as that builds up, there's not as much, there's nothing breaking it down, so it's just got a weaker point. With these fractures, they can come on slowly, so you can get pain. People can get pain in the femur, and you can see them on the X-ray before they've actually fractured. You can see a disshaping to the femur before they actually fracture. And also, it's quite common to get jaw's the second highest fracture. So with repetitive jaw movement, you can also get jaw fractures. But this isn't very common. This is just in a few cases. So there's a lot of research to show that the benefits much outweigh the negatives from the fractures, but precautions that can be put in place to try and make those risks less. So making sure the DEXA scan is done regularly, and if the medication can be stopped if you get a positive result on the DEXA scan. And it's still, so you can stop the medication, and they try and aim to not use the medication more than 5 years in a row. And so then once it's been stopped, it can be restarted without any negative effect. Also, it has quite a high half-life, so it can continue to benefit even after stop taking the medication. And then again, there's questions around whether you should stop taking the medication if you've had a different traumatic fracture, because it can sometimes stop remodeling, reduce the remodeling. There's a few articles on this, and there's not any firm evidence either way to say if it's negative or positive, but a few of the precautions say that you should stop a medication if there's been a trauma injury, just as a precaution. Okay, and then there's other strategies for osteoporosis. So obviously weight-bearing exercise and more like high impact loading has been shown to have a great benefit. On the Osteoporosis Society website has different protocols, and it says that if you're a normal adult with osteoporosis or without osteoporosis, you should be doing 50 moderate impacts on most days. So this includes jumping, skipping, jogging, or hopping. And if you've got a spinal fracture or are unable to do exercise, you should do at least 20 minutes of moderate exercise to try and prevent any complications from osteoporosis. But so we're trying to aim for 50 moderate impacts a day at the minimum. Also a balanced diet. So vitamin C and vitamin D is very important. And some foods can prevent the absorption of vitamin D and vitamin C as much into the bone. So very high wheat-based diets can cause reduced bone intake of vitamin C and D. Reducing the risk of falls. So if they are already at risk of osteoporosis, what can we put in place to stop them falling as much so there's less chance of fractures? So making sure that they're walking fine, walking aids are appropriate, and that they've got exercise programs to keep them strong and to reduce the risk of falls. Reducing alcohol consumption, avoiding smoking, and then being aware of steroid use. So like asthma and long-term steroids. So vitamin D helps your body absorb calcium. Calcium gives your bone strength and hardness. The vitamin D increases the risk of osteoporosis, so low vitamin D, and sunlight. So fish, sunlight, egg yolks, supplements, UV lights. And if you're with, when I've been on Tim with placement, he's made us go outside the minute he sees the sun, just for a couple of seconds. Okay, and then calcium. So that can be prescribed by the GP, and it increases the absorption of bisphosphonates. And you can get that from normal food like milk, dairy, greens, leafy spinach, sardines, and then it's in bread and flour as well. Exercise-wise, so studies have showed that in men and women, 1% increase of bone density rather than 1% of loss. So as a hopping study shows that you get increased bone density rather than losing it if you don't do any hopping. Yeah, let's read that bit. So these next articles below are there's 5 different articles, kind of in time order, about different progressions of bisphosphonates. and there's links to them on the side if anyone wants to read them after, but they're all mainly saying that bisphosphonates are beneficial for increasing bone density, and then some of them go into the details about the mechanism of how it works, and it also goes into some of the side effects, but the side effects are very low, and they can be spotted if you're having regular checkups, but it's just to be aware of. Tim, is there anything you want to really add in?
It was amazing. So I think they expect they about a 1% loss of bone density with every year you age over the age of 60. Could be 65, right? So what they found in this study, and it was a really big study, was if they just got people hopping like for 2 minutes a day, then they could actually not only reverse that 1% loss, but actually increase bone density by about 1%. So a year later, they had the equivalent of a 2% difference in overall benefit of bone density from a year of hopping. And that's just like 2 minutes a day. So it's just really a straightforward strategy just to get, I mean, some patients obviously won't be able to hop, but any kind of weight bearing exercise, I think is just so important for bone density, and that and diet. And I think that if you can get your diet right and you can get your exercise right and you can get some sunlight, then you've pretty much got a lot of the preventative stuff for osteoporosis. And I wouldn't say that medication is not necessary, but I would say that eating well, exercising, and getting some sunlight is a really good strategy as well.
Yeah, they said dancing as well is a good way of increasing it because it's something that people enjoy and it's easy to like advocate saying do this regularly, and it's quite high impact as well.
Good. I think that's all of our slides. Is that right, Sarah?
Yeah, that is all the slides.
Brilliant. Well
Sorry,
done. You've done really well.
Sorry.
Guys, any questions? Oh, this is a good video I found. So there's a good lecture on this aging website, and it talks about osteoporosis and how to, in inverted commas, reshape your bone. I think it's sort of this remodeling process. Yeah. Go
Can I just say, with regarding osteoporosis, I it's been a long time since I've read the article, but I do remember reading about how women find or create their sort of peak bone density actually in their early 20s, and so it's well worth thinking about that, especially with younger patients. If you do end up sort of chatting and it comes through in during your case history or just through your treatments with them that there is a family history of osteoporosis, that stage in life, especially in a woman's life, is really where you can make a difference to help prevent it further down the line. So it was I just remember reading it and thinking that's really, really interesting. If we can educate our younger female patients that maybe have a family history of it, then it might help prevent, the sort of later, prospect of having it. So I just thought I'd add it in case that's useful if anyone didn't know it. I'll go back to mute now.
Thanks, Kay. Anyone else want to jump in with any words of wisdom or great tips or questions?
Could I also just add in, I had a long-standing patient of mine who had pregnancy-associated osteoporosis, and it's not something that is kind of advertised is the wrong word, but is kind of taught or kind of out there as much. There's not a huge amount of information or studies done on it. So it's just something to be aware of, I think, as well, just when you are, you know, going through your differential diagnoses for people as well. Just thinking about if they have just had a baby and they've suddenly got severe onset of, you know, back pain or kind of something that you potentially could think could be a fracture. So just to kind of think about, you know, the slightly more rare ones as well, because it is out there. And I think it's the lady I treated, it took a long time for it to be diagnosed. So I think it's something just to be aware of when you are treating people as well.
Yeah, 100%, Neve. We've had another patient as well that saw us in Ballon Park surgery who had fractures post-pregnancy, and she ended up with 4 or 5 spinal fractures. It was really severe, and she went through a legal case with the medical teams that were looking after her, who essentially missed the fractures. So it's worth being mindful of that as well. And also, when you see fractures, you'll often see them around the upper lumbar and lower thoracic spine when they first present. So always look for those fractures which tend to be around the sort of lower bra strap area or just below. They tend to be so common at the base of the spine where most people get back pain. So you don't really see them. You can see them at L4 and 5, but much less commonly. You're much more likely to see them T11, T12, L1. So if you see people with pain that level, always be a little bit more sort of a bit of an alert. That could be something going on there.
Yeah, I mean, I was just going to add that as well, Tim, actually. That's the most common area that we see patients with having a fracture, isn't it? Just below that sort of thoracolumbar area, because of the stress load on that area.
Absolutely. Good. Anybody, any final thoughts?
I'll just quickly throw in, sorry, again, so about depending on where the fracture is and the medication, some of the medication has different affinity for different areas of the body as well. So that's something quite interesting. So I think it's the xeronic acid is more for spinal fractures. If you've got osteoporosis there, so to prevent spinal fractures. It also helps preventing other fractures as well, but that's the one it's best at preventing.
So can I add something on that? Is that okay? There is a classification online which suggests exactly what sort of drug would be preferable. So it goes as A as adequate, E as equivalent, and I think it's L, which is less sufficient. So hyaluronic acid is very good for vertebral fractures, especially when it comes to osteoporosis. It could be either vertebral fractures or hip fractures. It's very much adequate. The other thing is they do inject donimusab. I think that's the drug, isn't it, Tim?
We were actually looking this up a few days ago, weren't we?
No. Oh, okay. Yeah.
I don't remember the name of it. Do you remember what the drug was that they inject? I know they can inject for bisphosphonates. I mean, we mentioned it earlier, but there's also another drug, a very expensive drug. Did you manage to track that drug down, Sarah?
No, I haven't. No, sorry.
Yeah, I'll have to find out.
Yeah, I think they inject donimusab. I think they do it every sort of weekly. I think that's how they do it.
Okay. Yeah. Okay. Well, any last final thoughts?
Great job, Sarah.
Yeah, fantastic, Sarah. Well done. And I know it's probably a nerve-wracking thing, but you did really great. So Katie, is Katie around? Hello, Katie.
Yeah, hi, how's it going?
Yeah, good. Are you up for doing the next one in 2 weeks?
Yeah, absolutely. So that date will be, do you know?
It looks like Tuesday the 24th, although I know a couple of people have just asked if we can just do a poll versus a Tuesday and a Wednesday night. Although I do know we've had a lot more people here than we did when we did it on the Wednesday, but I might run a poll on Tuesday, Wednesday, but it'll probably be Tuesday, 24th of November.
Okay, yeah, perfect. I'll get something together then.
Brilliant. All right, guys. Nice to see you all.
Tim.
Thanks for coming.
one other, I think, is that medication denosumab? Is that what you're thinking of?
That's right. Yes.
Yeah.
Denosumab, that's the drug. Yeah.
There
So
you go.
they can either inject it every weekly, or it could be done, I think, in 6 months, isn't it? Isn't
Yeah, I
that
think
how
it's
they
every
inject it?
6 months. Yeah, and it's like
Yes,
I think it's an antibody type injection, isn't it? That helps.
Yeah, similar to that. They even do it oral as well. I know the rheumatologists who do it.
Sorry. Thank you.
Yeah, brilliant. All right, guys. We'll see you all soon, and have a great evening.
Thanks, Tim. Thank you.
Take care.
Thank you.
Bye. Bye.